Thank you for having me. I appreciate that I've been invited again to speak for the annual Oncology Summit for MOASC. And today, I wanted to provide an update. There are a lot of new drugs that have been approved or combinations that have been approved, but really with this short amount of time, I thought the biggest update that needs to be discussed is perioperative therapy for non-small cell lung cancer. And we have a lot of new options and a lot of new trials that have been presented over the past year. So just again, going back to the background of non-small cell lung cancer, and really back in the 90s, 2000s, we thought of lung cancer as non-small cell and small cell lung cancer, and then with genomics, we have understood that lung cancer is not one disease, but many diseases. And this, we now have more than 8 oncogenic drivers and multiple targeted therapies for these drivers. We also have an explosion of checkpoint inhibitors now for early stage, late stage consolidation, and for most patients who don't have oncogenic drivers will receive immunotherapy during the course of therapy. So again, we know in stage 4 disease, immunotherapy has been incredibly beneficial for a small subset of patients who have long-term survival and clinical benefit, but moving it earlier in the stage of disease has also benefited patients. And now we see a multitude of approvals. You see these here, and likely more to come. And so we now have adjuvant therapy, neoadjuvant therapy, and perioperative therapy, meaning neoadjuvant therapy and postoperative adjuvant therapy. I will talk about these. So when we think about neoadjuvant and adjuvant therapy, there are back and forth about why one may be better or the other may be better. Neoadjuvant, as medical oncologists, usually makes the most sense as we want to attack the disease as early as possible. And really, we want to eradicate micrometastatic disease that we may not be able to see on imaging. We have more completion rate of the treatment for patients, and we can see the pathologic response rate, and we can know whether these therapies we're using may be beneficial subsequently. And we can potentially eliminate live tumor cells that may be released during the time of surgery. For adjuvant therapy, as patients and surgeons are always most conscious of trying to get the patients to surgery as quickly as possible. And so the fastest time to surgery, obviously, is going for adjuvant therapy. There's no risk of pre-surgical complications because we'll see that some patients don't go to surgery after receiving neoadjuvant therapy. Longer treatment duration for systemic control after therapy because they're not having to go to surgery, and some more flexible timing and recovery time for patients. And this is going back a long way. This is from a meta-analysis of the adjuvant trials that were published somewhere around 2 decades ago now. But what we saw was when we looked at cisplatin-based adjuvant therapy, which were the majority of the trials that were published in the early 2000s, we had about a 5% benefit at 5 years, which is not bad, but still a large number of patients who still have recurrence and will die of their disease. And this is coming from adjuvant therapy with chemotherapy, but I think it provides a good example of who's going to benefit and who's not going to benefit. Because when we see all the treatments that we're giving and the potential toxicities, we have to understand that some patients, so what we see here in the orange, we have those patients who are going to survive regardless of getting therapy. And you can see by stage 1, stage 2, and stage 3, that decreases by the stage. And then you have the patients in red who are going to do poorly and die regardless of the therapy. And again, that goes up by stage. So then you see the green, which is the survival due to the therapy, which again increases by stage in general. And so more patients with stage 3 are generally going to benefit from the neoadjuvant and adjuvant therapy. And then there are going to be a small number of patients who have death due to the therapy, and that is more prevalent in the earlier stage. And so we want to give the patients who need therapy more therapy when they need it. We want to avoid giving toxic therapy to patients who don't. And that's always the premise for adjuvant and neoadjuvant therapy. So the first place we saw a benefit for adjuvant therapy was the IMpower010 study, and this was adjuvant atezolizumab versus best supportive care, and it was following standard adjuvant chemotherapy as per investigator discretion for those patients with stage 1B through 3A, and again, this was the previous staging, so these would all be stage 2 and stage 3 patients in today's staging criteria. And what they found was an improvement in disease-free survival. They did a hierarchical statistics on this, and they looked at first stage 2 and stage 3 with PD-L1 greater than 1%. And in that population, they saw an improvement in disease-free survival. And you can see on the right-hand side across stages that there was improvement, but the greatest improvement in the stage 3 patients and the greatest improvement in those patients with higher PD-L1 status. So the approval for this has been for PD-L1 greater than 1% for stage 2 and stage 3. And then the survival has been presented with several cutoffs. And again, here we see it by PD-L1 status. And we don't have a significant, statistically significant improvement in survival to date, but we see that those with higher PD-L1s certainly seem to have better survival. And next came the Keynote-091 study, or the PEARL study, and this was a study with adjuvant pembrolizumab. Very similar to the Keynote-01, or to the IMpower010 study, but this one, again, using pembrolizumab, allowing patients to receive chemotherapy as needed, and again, looking at disease-free survival, they saw an improvement in disease-free survival. Importantly, this was regardless of stage and regardless of PD-L1 status. And you could see here that even the 1 to 49% may have had a better benefit than those with the greater than 50%. I don't think any of us can explain that to date, but this allowed for an FDA approval for pembrolizumab for adjuvant across all stages and all PD-L1. And here we see, again, the disease-free survival specifically by PD-L1 status, and we don't see those significant differences that we saw in the previous study with atezolizumab. So we have 2 approvals for adjuvant in the adjuvant setting. But thinking about neoadjuvant immunotherapy, again, bringing immune checkpoint inhibitor therapy has been important, and we saw this in the advanced stage, in the metastatic setting. We're bringing in immunotherapy in the front line, especially with high PD-L1, improve survival over getting it subsequently. And so giving immunotherapy early changes the milieu of the tumor and can potentially activate T cells prior to the surgical resection, and some of those T cells may remain after. And so there may be a surveillance process that is stimulated even before the surgery. So the first randomized phase 3 study to show us a benefit was Checkmate 816. There were several phase 2 studies that we won't go through that showed some benefit previously. And what we have to understand between the adjuvant, the neoadjuvant, and even all of these neoadjuvant studies, and we'll look at some tables later, is that these studies are not all the same. The patients that enrolled were not all the same. So doing cross-study comparisons is very, very challenging, and we're prone to do it, but we have to understand that these are often very different studies. So again, Checkmate 816 is neoadjuvant nivolumab with chemotherapy versus chemotherapy alone in patients with stage 1B through 3A resectable disease. They had to receive surgery within 6 weeks, and then they got whatever adjuvant therapy was by the discretion of the investigator. Most of it did not include immunotherapy. And here we see just the characteristics. I think this is important, what we see here. When you look on the left-hand side, when you look at histology, we tend to see more squamous cell in some of these neoadjuvant studies. We also tend to see kind of a reversal of the stages. So in the adjuvant studies, we tend to see more stage 1 and stage 2 patients. In the neoadjuvant, we tend to see more stage 3 patients. This is an indication that our surgeons are making some decisions about who they're sending for neoadjuvant therapy. And here we see the pathologic complete response rate. And I think this was, when this was presented, it was New England Journal, very important information that we now had nearly a 25% pathologic complete response for immunotherapy with chemotherapy versus 2% with chemotherapy. Those who went to resection had a 30% pathologic complete response, and those who had primary tumor, the primary tumor only in the intent to treat group was, again, over 25%, and chemotherapy was less than 5% in all these groups. So the event-free survival also improved in these patients, and the median 31 months versus 20 months without immunotherapy, without nivolumab. So significant improvement in event-free survival. The overall survival here, median is not reached yet. We still don't have enough events to have the final overall survival, but we do see a trend toward benefit with the nivolumab and chemotherapy. Which means, I think importantly, is that we are potentially curing more patients without the adjuvant portion, because we'll get into the perioperative piece of this too. So at ASCO this year, the Keynote-091 study was presented, and again, this is a neoadjuvant study looking at pembrolizumab plus chemotherapy versus placebo plus chemotherapy. Patients underwent resection, then they went on to receive adjuvant chemotherapy as per the discretion of the investigator, then pembrolizumab or placebo adjuvant therapy. So what we are calling perioperative therapy. And again, as you see in the patient characteristics, in this study there were more non-squamous patients, but still more stage 3 and stage 3A and stage 3B patients than in the adjuvant studies. And here we see the event-free survival significantly improved with a median of about 47 months in the pembrolizumab arm and 18 months in the placebo arm. And when we look across subgroups, it's very small, I know, but what you can see is that all of the subgroups looked at had a benefit with the pembrolizumab. An early evaluation of overall survival, again, this was presented this year at ESMO and published, and we have an improvement in overall survival with a significant, statistically a significant improvement in overall survival, but still not reached for the pembrolizumab arm and 52 months for the placebo arm. So we're seeing an improvement in overall survival and a significant benefit in event-free survival. Also presented this year was the ADAURA study, and again, similar setup, neoadjuvant chemo plus durvalumab versus placebo, followed by surgery, and then durvalumab versus placebo. More significantly higher number of stage 3A and 3B patients, and again, improvement in events-free survival. You're starting to see a pattern here. So definite benefit for these patients. In the ADAURA study, they also looked at clearance of ctDNA, and what they saw were more significant clearance of ctDNA in the patients who received durvalumab, and on the right-hand side, you see the clearance during the neoadjuvant treatment, and so pre-surgery, 2/3 of patients had clearance versus 40% in the chemotherapy arm alone. The Checkmate 77T study, also a perioperative with nivolumab. So this was Checkmate 816 basically with the adjuvant portion at the end of it. And again, this is an earlier cut, but we also see an improvement in event-free survival, and this is across most subgroups, but more benefit in the higher stages and in higher PD-L1. And again, event-free survival by their baseline disease, those with stage 3 had more significant benefit, and those with higher PD-L1, greater than 1%, had more significant benefit. So this is, again, cautiously comparing these, so Checkmate 816 in the top left, and then the other 3 that were the perioperative, where we see we're around 60% of patients that are disease-free somewhere around 2 years. And so at this moment in time, they look very similar. And again, now we have to understand how to treat these patients and how best to deal with patients who have pathologic complete response, who don't have pathologic complete response, and start to understand the subcategories. So again, with all the caveats of cross-trial comparison, I think this type of table does help, and it helps to understand where we're at. But again, the event-free survival, we're seeing kind of 0.6 hazard ratio for all of these, very similar. And again, these are highly concentrated with stage 3 patients that we know can benefit more significantly from adjuvant and neoadjuvant therapy. And then in the adjuvant setting, the hazard ratio in the 0.7 range, and we do not yet have the overall survival benefit. So some of the cross-trial comparisons here are seen. There's one, the NeoTorch study that was done in China has only published on their stage 3 patients. The majority of their patients were squamous cells, so very difficult to compare. Some of them did include EGFR and ALK patients, but not, the Keynote-091 did not include it in their analysis. And some of these did have differing numbers of stage 3B, which many of these stage 3B patients we might not even think about as surgical candidates. And again, that's a discussion for another talk. What's the cost of adding the adjuvant therapy for patients? So the toxicity was minimal, but it was twice the amount that we saw for patients who had placebo. So grade 3 to 5 adverse events, about 10%. So probably what we would expect, but it's not without toxicity. So where we are now is that we have the ability to give neoadjuvant therapy followed by surgery with an FDA-approved regimen. We have surgery followed by adjuvant immunotherapy with 2 FDA regimens. And then we have chemotherapy and immunotherapy followed by surgery followed by more immunotherapy with 1 FDA-approved regimens and others that are likely to be coming along. But we really do need to understand which is better. We've tried to do this before, neoadjuvant versus adjuvant. That was way back many years ago, and that accrual did not go very well for these types of trials where we tried to compare neoadjuvant to adjuvant. So these are difficult to do, and I'm not sure that they can be done. But when we look at event-free survival by that pathologic complete response, obviously these patients who have pathologic complete responses do much better. So who are these patients that we may be overtreating? How do we understand these patients and potentially not give adjuvant therapy to some patients? And so good pathologic complete response, potentially randomizing those patients, those with poor, if they're not having a response, is it worth giving further therapy with a therapy that may not have worked, because we know in the metastatic setting that not everybody has tumors that respond to immunotherapy. So I think these are types of things that we need. We're also looking at studies that incorporate minimal residual disease. And I think we're moving very closely to the end of the time. We also have targeted therapy for the early stage setting. I think just to bring this closely, we have the ADAURA study that showed an improvement in disease-free survival for osimertinib following adjuvant chemotherapy, and then osimertinib for 3 years versus placebo, improvement in disease-free survival, which continued to show improvement with an update in 2022. And then at ASCO this year presented an overall survival benefit, and that's across all stages. And you see here a hazard ratio of 0.49, which is a pretty impressive hazard ratio. It's still a low number of events that have occurred for survival, so there's a longer follow-up that's needed, but across stages there's benefit. So again, there still are going to be patients that we are overtreating with osimertinib, and there's more toxicity, though this is a relatively well-tolerated medication. I think understanding who is going to benefit and who is not going to benefit and who might be the best patients to treat may be something that may be helpful to understand, and whether minimal residual disease or something could help us in that area. Moving forward, the last is, so if we can use this in EGFR patients, what about other targets? I think not all targets are equal. The response rates with these, some of these targeted agents are not the same as they are with osimertinib, and some of the toxicities are more challenging than what we see with osimertinib. But one of the drugs that is relatively well tolerated and shows significant benefit in the metastatic setting is alectinib for ALK positive non-small cell lung cancer. And again, this was the ALINA trial. Interestingly, this was patients, again, with stage 1 through stage 3 who received 2 years of alectinib versus chemotherapy. So in the alectinib arm, chemotherapy was removed altogether. And these patients do very well. So ALK patients, we know, have about an 80-month median survival, even years ago when that was published, before we had the number of ALK inhibitors that we have now. So they tend to do better than other patient populations. And we see here, even at 3 years, we have a 50% disease-free survival in the chemotherapy arm and 88% in the alectinib arm. So incredibly good disease-free survival. I'm not sure we're ever going to see an overall survival because patients do live a long time with ALK positive non-small cell lung cancer, but I think it's a reasonable option and improved across stages and something to consider for our patients. CNS disease-free survival also significantly improved over chemotherapy. Toxicities you see here, obviously we see significant toxicities with chemotherapy, and you see some toxicities with the alectinib, and most of them are grade 1 and grade 2. So many questions that we have. What's the optimal duration? Again, osimertinib used 3 years. Is longer better? Alectinib used 2 years. Is chemotherapy necessary? And so the alectinib study, the ALINA study, took out the chemotherapy for those getting targeted therapy, and significant benefit there. So patients who are adverse to chemotherapy may appreciate going on to a therapy without receiving postoperative chemotherapy. Do we use this in the perioperative, in the neoadjuvant setting? Both of those trials are being done. Which patients benefit? Which patients are we treating too much with these therapies? And how do we intensify or de-intensify for the right patients? And I think these questions hold true for most of adjuvant and neoadjuvant therapy for our patients. So now we know perioperative chemoimmunotherapy followed by adjuvant immunotherapy and adjuvant immunotherapy is really a significant advance to improve outcomes for non-small cell lung cancer, and very important for our patients. It will help to have even more discussions at multidisciplinary tumor boards for these patients that are potentially surgically resectable. We need to understand how much therapy is needed after pathologic complete response, and for those who without pathologic complete response. We need to understand biomarkers, and I think minimal residual disease is not quite there yet for lung cancer, but I think that's probably the direction that we're going. We know that osimertinib can improve overall survival for EGFR patients, and alectinib improves event-free survival for ALK patients and should be considered. And this also means that biomarker testing needs to be done in the perioperative setting, because if we give chemoimmunotherapy to a patient with EGFR, we may cause significant ILD when we try to give them osimertinib post-surgery. So understanding that biomarker pre-surgery is going to be important. And that's all I have today, and I'm happy to take any questions.